So hello, everybody. I'm Cassandra Furman with the Arch National Respite Network and Resource Center, and I'm so glad you could join us. Probably some other people will be popping in during the meeting, but we would like to go ahead and get started right away. And I'm especially happy. Well, no, I'm sad too, but I'm happy that we get Dr. Ray Kirk today, who will be really retiring. He's been sort of retired like me for a while, but he's taking the final leap into true retirement, where he will grow grapes in Vermont and make wine, which I will someday sample. But Ray has been a mentor of mine since I first came to Arch many years ago. Pretty much most of what I know about evaluation I learned from Ray in terms of real evaluation work that we do with Respite. So I thought, hey, as a swan song, we'd identified talking about pinpointing outcomes and indicators. And I thought the best person to talk to us about that is Ray. So I'm so delighted to have Ray join us. And that's the first part of our call today. Here's the agenda. Ray will talk about pinpointing outcomes and performance targets for respite programs to measure. Then I'm going to share some resources for selecting appropriate measurement tools, some Arch resources and other resources from national organizations. And then during the presentations, and especially at the end, but we really want to hear from you. So if you have questions or comments as Ray and I present, it's really okay to put them in chat. We'll leave specified time for comments, but you don't have to wait till then. If something comes up and you really want to know more, please don't hesitate. So that is the plan for today. But right now, I'd love for you to just put in the chat box who's here. I see your names up there, but please put your name and your state. And if you have anything you really hope to gain from this meeting today, jot it down for us. We'll just take a few minutes to see your messages. So this is your chance to say hello to everybody. And I just put in, I'm Cassandra, hello. I want to hear what other people are measuring as well. So Taylor, hello. Lita's here from Arizona. Abby from New York. Help me pronounce your name. In Nevada, is it Yasmin?
It's Yasmin.
Yasmin, thank you. And forgive me for not being able to pronounce it correctly, so welcome.
That's okay, it happens all the time.
I imagine. Doris, Dina, Marilyn from Idaho, Lynn from Idaho. Welcome to all of you. So before, I think if other people come in, we'll just acknowledge them later at this point. So without further ado, I'm going to hand this over to Ray. And Ray, just tell me when you want to move the slides. Thanks.
Okay, thank you, Cassandra, and welcome everyone. This really, I'm going to try to be as informal and conversational as I can with this, because I'd really like to engage throughout and then at the end in a kind of an applied session to talk about maybe some things that you're wondering how you could measure, how you might go about thinking about outcomes, and then the performance indicators that relate to those outcomes. And to set the stage, I'm going to show you the two primary sources of the material that I'm going to talk about. You've actually, I think, received these as attachments to from communications from Cassandra, but I've kind of cherry picked some quotes and sections to set the backdrop for thinking about outcomes, why we need them, where do they come from, and why it's all important, particularly with respect to the development of an evidence base for respite in an era where there are a lot of assumptions made about the effectiveness of respite, its place in the continuum of services, its contribution to other service plans, maybe multi-factor plans for, the elderly or people suffering various disease processes like Alzheimer's and dementia. Respite isn't necessarily the only service that they might receive. In fact, probably the caregivers of people with those issues should be receiving more respite. So it really cuts both ways. But the task that I've been focused on for most of the last 10 years in my work with Cassandra and Jill and others at Arch is to work towards establishing that evidence base. And part of that mission or part of that agenda is to assist the providers, the grantees, the other constituents in the respite community to become more familiar with developing outcomes, linking them to certain performance measures, and then engaging in data collection and making a contribution to that effort to develop the evidence base. It will serve us well in the long run and increase our competitiveness for funding and increase our credibility in the cross-disciplinary environment that increasingly we find ourselves working in. So that's sort of my agenda. And as Cassandra said, any time you have a question or a comment, pop it into the chat box. I personally won't be monitoring that. I've asked Cassandra and Jill to monitor that, and Susan too. She's here as well, Susan Summers. And if there's a question that pops up, they'll let me know, like in between slides, so I can address it. And then at the end, we'll have hopefully a more, we'll go to Hollywood Squares, turn off the slides, and maybe have a multi-square conversation for as long as we need to do it. Okay, Cassandra, if you could go to the next slide, please. This is the cover shot of the final report from the expert panel on respite research. Jill and I are the primary authors of this volume, and Susan was tremendously assisting editor, and I have kind of a joke with my colleagues at Arch when I write, why use 2 words when 5 will do? So I tend to over explain and use a lot of words. I've been accused of liking to hear myself talk, but she's been very effective in cutting that back to a more pithy publication. And many of the slides, 7 or 8, will be screenshots of things that you can find immediately by opening up this document from the links that Cassandra has sent you, and dive into it if you're so moved. If you're at the point where you're designing an evaluation or designing a research study or participating in a research study, I I think, a pretty good volume. It's pretty dense, but there's a lot of material in there that will be of help to you. Next slide, please. And this is the other one where there'll be a few screenshots from this one as well. This is the title, Measuring Systems Change and Consumer Outcomes. And it really focuses on, as the banner says, the performance metrics for respite programs. Cassandra is the principal author of this document, and she'll be referencing it later, I'm about to say later in the program, later in the meeting. But you have both of these, and I really commend them to you for your future use, if we can excite you with their contents. Okay, Cassandra, let's go to the next slide, please. Okay, this is a graphic that represents the 6 key recommendations from the expert panel. And for those of you who don't know who that expert panel is, about 10 years ago, perhaps 11 years ago, under the auspices of Arch, in cooperation with the Administration for Community Living, we convened an austere group of folks, published researchers, foundation representatives who had an interest in funding respite, some advocates, all in all, I think there were 13 or 14 people on the panel who would be recognized generally by their peers and by the community at large as kind of being the brain trust of respite and respite research in particular. And we spent 3.5 years discussing the features of the existing literature that were positive, uncovering some weaknesses in them, some holes. And in the end of that process, the panel came up with 6 recommendations. I had really the pleasure of facilitating that entire process with Jill, and this is sort of the collective wisdom of the group in one graphic, insofar as it relates to what should we do going forward in research and evaluation with respect to respite. The upper right hand, sort of the reddish tile in the puzzle there, number 1, the recommendation was to improve research methodologies. We found a lot of instances where studies had been published, but the designs were weak. The measures were not direct. In many cases, there were no measures. They were theoretical or philosophical articles about respite, what it was, what it could do. And in many cases, the focus of the research, that which we call the dependent variable, that's which is being studied, was the care receiver, such as Alzheimer's victims or people with dementia who were being served in adult day programs. The respite was the adult daycare program, which I guess in sort of vicariously conveyed to the caregiver, but mostly what was studied was how's the care receiver doing as a result of having been in the day program. So we felt, the group felt, that a lot of the research actually missed the point. When you call something respite, they felt, gee, we really should be focusing on the caregiver. The respite is to relieve the caregiver of the caregiving responsibilities for some period of time. And that should result in something good for the caregiver, as well as perhaps the care receiver, the family, the community, whatever it might be. So that led to the second tile piece here, which was the recommendation to focus on individual, family, and societal outcomes. That is, how is the individual caregiver the individual care receiver, the family, the community. How are these things better or different as a result of respite having been provided? So it's really, it is kind of the essence of outcomes. How are you different? What's different now than before after you've had this service? The remainder of these, we won't spend as much time on these, talk about cost, benefit, and cost effectiveness analysis. A lot of the credibility of respite has been hinged to its ability to do things like delay institutionalization or out-of-home placement to reduce the number and frequency of hospital visits or falls or, you know, negative occurrences in the lives of the caregiver and the care receiver. And that's a real mixed literature on that. By and large, it hasn't really demonstrated that respite is cost effective, but there are a lot of methodological reasons for that. Data mining, huge financial systems like Medicare, Medicaid, some of the veterans budgets that have included respite. It's pretty hard to disentangle those costs and isolate those that are attributable solely to respite. So we need to do some work there as well. Systems change to improve respite access, improving respite provider competence. Respite's only as good as the competence of the people providing it. That was not a well understood or articulated variable in the literature at the time. And then assuming that we do succeed in conducting good evaluations and good prospective research, the last tile here is translating research findings into best practice models. And ARCH is all about that, and the research community that collaborates with ARCH is all about that as well. But I really want to jump back to number 2, spend the rest of our time focusing on that. So if we could have the next slide, please. This is well, an excerpt from the report that reiterates and then further explicates the reason to focus on individual, family, and societal outcomes. And I'll read it because I know it's a little fuzzy on there, and I apologize for some of the quality here. I was doing screenshots from the electronic copies of this. When I blew them up, some of the type got a little fuzzy. So I'll just read it because I pretty much have it memorized anyway, but I'll relieve you all of leaning forward and squinting. What this says is the panel, that is the expert panel, identified the family caregiver as the portal of entry for future respite research and set the expectation that at least one outcome relating to the caregiver's well-being or quality of life would be measured during any such research study. So clearly there, the focus is on the caregiver as the portal of entry. Now they go on to say that this doesn't mean you can't study benefits that accrue to other people, like the care receiver, like other members of the family, like society at large. But it really begins with a focus on the caregiver. And what is it that you expect to happen to, for, or with that caregiver as a result of respite that will result in some kind of a measurable or observable improvement in some other variable, such as well-being, quality of life, reduction in stress, things of this nature that you could then attribute specifically to the provision of respite. So again, it kind of further explicates in a formal statement that that issue of really, you know, what is the unit of analysis? It begins with the caregiver. What is it that you're trying to do? Improve the well-being of that caregiver, which may lead to other good things later on, like delaying out-of-home placement or delaying institutionalization or keeping a family together as a family unit. So again, those are things that we can measure as well. they may be measured a little farther down the line when it comes to, pardon me, attribution for respite. Okay, next slide, please. So again, these are little snippets, some of which I just thought I would enjoy sharing with you. There are good reasons for identifying outcomes and for determining ways to measure them and calling it performance measurement. And one of the most important, and again, to some extent, it relates back to funding and credibility, is that performance measurement demonstrates that resources are being used for activities that result in positive change. There are lots of programs out there, programs that I, over the years, have referred to as programs of vague good works, well-intentioned, big-hearted, friendly people wanting to improve the human condition, running around doing a bunch of good things. But there's not necessarily a model that you're looking at. There's not necessarily a clearly defined service population or a well-defined outcome. So although people feel good about what they're doing, and some of the recipients of their activities might feel that they're better off, it's hard to make a case for it, and therefore hard to defend and compete for funding for it. So being able to demonstrate that what you're doing, those activities, are resulting in positive change is directly the task and the association between performance measurement and your services that you provide. So next slide, please. And part of identifying good performance measures is knowing what success is. It's not always apparent. It's not always evident, particularly to people outside of our peer community or people that share the jargon of our chosen field, exactly what success is. So as this says, if you provide a particular respite service, which in research and evaluation parlance, again, we call that the independent variable. That's what you do. You control that. If it's effective, then you want to know what positive outcome you would expect to observe. That is the dependent variable. That depends if there's a causal link on what we've done, which is the independent variable. So you begin with the independent variable. It impacts the caregiver or the family or the community. But you have to decide and then define what is it that we're looking for. If you don't know what you're looking for, you haven't defined it precisely enough, then when you go to the next step, which is try to identify performance indicators of those variables, the task becomes very challenging. And you begin to see that kind of fuzziness in designs and in the ability to attribute good outcomes to the activities that are provided under the rubric of respite. Next slide, please. Let me just pause there and ask if anything pop up in the chat box yet, Cass? You're muted.
No,
Oh,
no,
okay.
nothing's popped up, but I would love for you to clarify, and maybe Jill would like to kick in. We're talking a lot about research, and I just want to ask you or Jill or both of you to talk about, is there an expectation that our lifespan respite grantees actually engage in research? Is that an expectation, or how do you see that?
Well, first of all, let me say that everything that I'm talking about, if I use the term research, it also applies to evaluation. The difference is, to some degree, the comprehensiveness of a particular examination, whether it's a full-blown research study with comparison sites or subjects. I hate to use that word in the social sciences, but that's the kind of the highfalutin bar, the research bar. but we should all be evaluating our programs. We should all be deciding or identifying what it is that our programs are intended to achieve with respect to altering a life course trajectory or reducing the likelihood of a negative outcome or improving things like quality of life, and then measuring something that that gives us that indication. Now, is there an expectation? I certainly don't believe that there is an ACL expectation at this point, at least, that grantees must engage in research. But I also think it's in everybody's best interest, grantees, providers, and Arch and everybody else alike, that if the opportunity presents itself to participate in a research study, either to contribute data to somebody else's study or to evaluate your own program, which I think everybody should be doing to some degree, then the more comfortable you are understanding that it's not necessarily a dangerous or horrendously time-consuming event. It's not one where you're violating confidences automatically of people who are receiving services. It's all kinds of protections, and there's a lot of stuff in those two resources that will help sort that out. But the idea of being comfortable with it, our colleague Kim Whitmore at, I guess she's now at Marquette. She's gone from Wisconsin to Marquette, we've collaborated with. She directs the break exchange, among other things, and is a rising star in the respite research field. Refers to programs as being research ready when they understand, okay, what is it that we're trying to do here? We're trying to gather some data to demonstrate that the services that we provide result in good things. And if you don't want to do that yourself, you find somebody either like myself or like Kim to collaborate with to help you wade through those pesky kind of scientific things that that most people in the serving communities, they didn't go to school to learn how to do that. They went to school to learn how to actually provide the service. So, we sort of stand at the ready to jump in and help with that. Is that helpful, Cassandra?
Thank you. Thank you. And I don't know if Jill or anyone else has anything to add. A lot of people sort of shudder at the idea of research or evaluation or performance measurement. But certainly especially with the lifespan respite grantees, if you say you're going to do something and you're going to do it to a certain degree when you apply, it's critical that you measure that performance, I believe. And it doesn't have to be the big R research, but we should be tracking whether or not and to what degree we're reaching our performance targets. And we'll talk more about how to do that later.
Okay. Thanks, Cassandra.
Sure.
Yeah, and any of you listening, if you have questions on this, this is a values neutral, friendly forum. So please, jot down questions and either pop them in the chat box or save them until the end when we can go into Hollywood Squares mode.
Yeah, or concerns, questions, or hey, I'm worried about something. That's fine too.
Yeah. So the previous slide, we don't have to go back to it, but the previous slide suggested that we need to know what success looks like. That is, if it happens, will we know it? This side, and again, these are all excerpts from those two resources, advise us to define success in measurable terms. I remember years ago in a child welfare environment where a social worker asked us, well, how do you know if you succeeded in working with this family in which child maltreatment has occurred? And she said, I really want my parents to feel good about themselves after I'm done. That's fine. That'd be really nice. But what I really want to know as the commissioner is, are the children no longer being maltreated, and what are the measures that give us that? So success in getting one outcome might not be the definition of success that has a legal implication to a family. That's an extreme case, probably way beyond the things that most of us deal with in the respite environment. But polemical examples sometimes are easier or more clear to make a point. So I will do that from time to time. But in this case, this is simply define things in measurable terms. So if I define success in a way that I can either scale it, or there's a standardized test that I could use to give me a score, or I can count it. If it's a good thing, I want the count to go up. If it's a unfortunate or bad thing, I want the count to go down over time. So again, kind of keep in mind as you're defining success that if you define it in measurable terms, and let's say, just for example, it's something that you can count and you want the count to go up, well, then your performance indicator is going to reflect those properties. It will be a numbers-based indicator, and you'll figure out a way or time periods, count once a month, count every week, whatever it might be, and then you plot the counts and see if indeed it's going up. So again, it's not necessarily a rocket science kind of leap into the realm of making statistical or measurement models out of your outcome statements. But if you begin that process by saying, okay, here's what I want to have happen. I want the stress level of my caregivers to go down, because we think it's the stress involved with being a caregiver is negatively affecting caregivers' health. It's threatening the stability of the family relationship. There are a number of things that over a longer period of time, high levels of stress result in bad outcomes. So near in the immediate future, we want stress to go down. That's how we think we're going to help this. That's a logical thing. That's part of the logical connection between the things that you define as success and when you measure them, how long you measure them for, and are you focusing on the individuals that you can then add together into groups and say, well, now we've got a group of people who benefited from this and they all look like they're getting better or improving in the same way, rather than waiting for a year and then measuring a whole people all at once. And if it doesn't work out, you've kind of maybe lost that year without being able to improve your service. So defining in measurable terms and then getting about the task of measuring. So where do we start? Next slide, please. Thank you. Well, we start with a concise, inclusive definition. Now, again, this definition comes from the expert panel's deliberations from that manual, and it does take on a kind of research and evaluation perspective, but it is concise, and I think it reflects, hopefully, if we read through it, it reflects some of the things that we've been talking about so far. And that is that respite is the planned or emergency service that provides a caregiver of a child or an adult with special needs some time away from caregiver responsibilities so that the child, for that child or adult, and which results in some measurable improvement in the well-being of the caregiver, care receiver, and or family system. So again, we begin with the caregiver. The caregiver is the receiver of the respite service, and we're hoping that that service results in a measurable improvement in the well-being of the caregiver, and also, not necessarily incidentally, maybe fully on purpose, the care receiver and or the family system. So I think that serves as a pretty good definition of respite, in particular because it does begin, that recognizes that portal of entry being the caregiver. Okay.
Ray, we do have a question if you don't mind.
Okay, no, fire away.
from Leanne in Massachusetts. And she says, the challenge I have experienced is the care recipient's condition or symptoms are not static. So it's difficult to measure the impact of the respite intervention on the caregiver. Is there a way to account for the variability?
Well, yeah, you can track that as well. The challenge when you start layering on additional variables of interest and study, the evaluation process or the research process does become more cumbersome, more resource intensive. But yes, it's true. You know, we all age, and things that affect us as we age are going to affect us more and more the older we get and the longer we're tracked. So I guess this would be the kind of thing where we'd have a pretty focused conversation on the particular population that you're providing services to, how advanced the disease or aging process is in the population of care receivers, and then as well the entry level condition of the caregivers with respect to the outcomes you want to measure. So if, for example, again, to speak in extremes, if you're receiving referrals from mental health consultants who have noticed a large population of very depressed caregivers or people who they then identify as caregivers, and they're at the point where they're seeking professional help or they're seeking placement for their relatives, that's kind of a deep end entry for the service. And it's likely that, you know, while respite will help, there may be some other things that need to be done as well. So one of the things that might suggest is that we try to back up a little bit and identify caregiver, care receiver dyads that are headed in that direction, but provide respite at an earlier stage of the process. That's really getting into the research level of things where you're manipulating variables in various directions there. But it's a challenge, and you know, if you can begin with an evaluation where you could say we've been able to, if not decrease stress necessarily, but we've been able to prevent further deterioration, or if we have been able to, if these are people who you are beginning to serve because they are seeking out-of-home placement or hospitalization, that can then be delayed as a result of care. The issue there with respect to attribution is one of having the group of people that you're serving and comparing them to similar people that aren't getting served, and you look for the difference. But at least if you begin with measuring and monitoring those outcomes, the stress and placement outcomes of the families that you're dealing with, you have a starting point and one that will inform how you might either solicit or receive referrals, and how you might design a measurement system that actually accounts for temporal or time-dependent deterioration between one of the two members of the dyad in that situation. Does that help?
Well, Marilyn actually followed up and said, good point, Leanne. I wonder if developmental evaluation would be advisable as a measure of an intervention in a dynamic social environment.
It might be, might well be. That's a little beyond my ken, but I'm sure that it could be done. It's likely to, require resources. You have to assess and then monitor. There should be some kind of a standardized way of assessing the developmental stage or the deterioration stage, and then continuing to track that. So those additional measurement systems and strategies all bring with them some expectation of additional expertise and resource commitment to gather the data. It'd be great if there were pools of money available to fund these kinds of research questions. I don't think we're quite there yet, but one of the things that we're trying to do at Arch is to raise the consciousness among the foundations and various federal agencies that these are things that are worthy of study, and to get them to commit some resources and funding to it.
When we get to the Q&A, I'm hoping people will go off mute because I'd love to hear more about your ideas here. So I'm gonna, next slide, Ray?
Yes, please.
Okay,
Yeah.
thank you.
Yeah. And this is a graphic that shows that process. It might be a little bit confusing because the arrows are going from right to left here, and our thought processes, as I've begun to describe them, are going from left to right, which is to identify the outcome that you want to achieve, and that is, what will the caregiver's experience be with respect to improving something? In this case, the example is well-being. Now, well-being is a pretty vague term, but you can select particular components of well-being and home in on those. But so let's say you just want to reduce stress, or you're trying to improve the relationships within the family. That would be the outcome that you want. The indicator is the caregiver's report of, in this case, decreased stress or decreased depression, or improvements in relationships between caregiver and care receiver, or perhaps caregiver and other members of the family. And then the measure might be something like an index of clinical stress, or Beck's depression inventory, or other standardized measures that you might find that bring with them reliability and validity as a measure, so that if you use them, you have credibility with people who say, well, how are you measuring that? Well, what's depression? Well, it's depression as defined by the Beck team and their assessment instrument, the Beck Depression Inventory, or the very generally available index of clinical stress. So there are ways to obtain data on these that relate directly to your indicator, and then the indicator is, hopefully, if your logic is sound, responsible for achieving the outcome.
Yeah.
So again,
I just wanted to share, you talked about the arrows, and I actually created this. And I think if I were writing a plan, I would start with the outcome. And then I would go to the indicators. Well, how would I know? What would I see or hear that tells me that outcome is being measured or is occurring? And then the measurement would be the next step that I would write. Well, what are my data sources? How am I going to do that? And then the reason I have the arrows going the other way was the measurement tells us if the indicators are being achieved. Right. If the indicators are being achieved, then the outcome is being achieved. So I should have had arrows going in one direction and then back in the other.
Well, I chose this graphic because it had those three things juxtaposed. You had created it for a different purpose, but I'm not that dyslexic, but you can, depends on what you're doing. You define your outcomes and then move to indicator and measurement. In one context, in another context, which is the instrument that you wrote, that you authored. You're using it for a slightly different purpose.
Yeah. Oh, no, I think this is a great example, though, that you write it a certain way. You have to plan. And I know you're going to get to that in a second with logic models. So thank you. I apologize to interrupting.
Okay. No worries. Next slide. Thanks. The next two slides are simply examples taken from the expert panel book, where we put in a whole, I think there's 3 or 4 pages that begin with outcome categories. This one is quality of life. And then it talks about proximal outcomes and distal outcomes. And proximal outcomes are those things that you can know pretty soon, after a period of weeks or at most months. In this case, if you're defining quality of life as with respect to stress level, then the outcome that you want is some reduction in stress. You might be focusing on the sense of support. You're trying to increase that sense of support that caregivers have. And in fact, during the COVID-19 pandemic, which is obviously still ongoing, I'm sure many of you witnessed the necessary decrease in the amount of face-to-face and hands-on kind of respite, which was in fact the support base for many caregivers. So one of the things, if you're, for example, you're trying to evaluate programs or research programs, insofar as COVID has had an effect on them, you might be looking at the proximal outcome of, well, our caregivers have a sense that their support base is eroding and that their anxiety is going up, their stress levels are up. So you might have a couple of things in here that you're going to look at pretty quickly in the evaluation process. I draw this to your attention for two things. One, we've been talking about quality of life, and here's a whole list of things that you could use to define quality of life. But as important, I wanted to, this is the first time we've seen this, the difference between proximal and distal outcomes. And that's simply, it's kind of a highfalutin word, academic way of expressing. Proximal means pretty soon, now. We're going to try to get this stress level down. Well, what's the distal outcome related to that? Well, that's something that happens, at the end of the year, or maybe at the end of 100 cases that may span over 2 or 3 years. And what those distal outcomes are is improved sustained quality of life for both caregiver and care receiver. So if you are able to reduce stress and increase the sense of support, and that leads to, after you've done this with 100 families, a sense and a measured sense that the quality of life for the family has improved. The caregiver is happy with the situation, happier than they were when they entered your study. The care receiver is still at the home, or if it's a child or not somebody who's in advanced stages of dementia or suffering from Alzheimer's, that they are participating as a family member and enjoying that participation. There are little interviews you could use, to gather those data at 3-month intervals for a year. The point is that your proximal outcomes actually become your distal outcomes if you do them over time. They're not different. I mean, you might have one big one, like say, okay, we're going to look at everybody at the end of a year and see what the hospitalization rate or the placement rate has been. But invariably, your proximal outcomes will become your distal outcomes after enough time has passed and you've measured enough families, enough caregivers to make that leap. Next slide, please. This is another, whoops, I did that here. This is another example from the book. It's simply the outcome category. In this case is family relations. I chose this one because, again, we talked about it in passing a little bit earlier. But the proximal outcomes are, again, these are just examples, but they've been offered with some degree of confidence and strength. The quality of the marital or partner relationship between the caregiver and the care receiver, the perceived strength of the relationship, relationship with other family members, which is a pretty ubiquitous item in families where the care receiver may be younger and there may be more than two, a dyadic caregiver care receiver situation. So things that you could measure might include things like, the time spent with non-care receiving family members. And you might use things like Hudson's scale of marital relations, which is a really quick 25 item yes, no, agree, disagree, 3 or 4 word prompts. Takes about maybe 8 minutes to administer. And again, it's a standardized test. It has a lot of credibility in the measurement community. And you could do that at intake. You could do it at 3 months, at 6 months. So you've got either a time series measurement or at least a pre-post of some kind. And that, hopefully, if you're able to maintain or improve the family relationship, improve the relationship of the caregiver with other members of the family, then you might see, in the distal sense, sustained family continuity, fewer out-of-home placements, fewer divorces and separations, abandonments, whatever, it all happens. Relationship stability, again, decreases in separation and divorce. You might see indicators like families figure out how to take vacations together or take vacations apart, that they become comfortable with that. Again, the proximal leads to the distal. You don't necessarily want to wait a year or 2 years or some other undefined at this juncture period of time to take a single measure and hitch your wagon to it and hope that it works. You want to be measuring those things along the way. Okay, next slide, please. Okay, I threw this in because I thought it gives a kind of an interesting thumbnail on identifying research and evaluation topics. And if we selected these and ran studies on them and found that we had positive effects with respite, that could make a pretty significant contribution to the evidence base for respite. And this simply says and this, again, this is a finding from the expert panel, and mostly it's a finding in the absence of occurrence of things that they think should be happening, that we should be spending more time studying family caregiver relationships, marital status, the impact of caregiving on caregivers' ability to maintain employment, its impact on family economic stability, not just cost benefit with respect to saving federal money or service money, but how about the economic condition of the family itself, where there may be, this is something that's almost never studied, extra out-of-pocket costs that are borne by the family even during the provision of respite in order to achieve other outcomes like family stability. Social interactions, there's a lot of isolation that goes on in caregiver care receiver dyads, and respite can have an impact on that, but it's very rarely mentioned or studied, at least up until now. Maltreatment of various kinds between the caregiver and care receiver. And then caregiver health, which has not been well researched. There's a lot of anecdotal evidence that caregiver health deteriorates at a faster pace than non-caregivers in the peer group because of the stress and isolation and depression and things like that go along with it. So there's no shortage of researchable or evaluable topics. And we just need to remind ourselves sometimes that there are fertile areas to look at where we could find positive benefits from the provision of respite. Okay, next slide. Thank you. This is actually from a whole different curriculum. It's one of my favorite sayings. It does not come out of either of the resources that I have shared with you, but I think it's pretty compelling. And it relates to the design of programs. Again, are you a department or a program of vague good works, or are you a program that has a specific model and it's well defined and you deliver it in a certain way? And the statement from R. Spencer Darling comes out of the business literature, and it says all organizations and systems are designed either intentionally or unwittingly to achieve precisely the results that they get. So if you're not getting the results that you want, let's say you've engaged in a process of measuring performance, you're trying to achieve certain indicators and they're not happening, then it's time to look at the design, because whatever is happening either because of or in spite of what you're doing. So those measures, that's why I say it's important to focus on the proximal so that you get a heads up if things aren't going well and you can make some adjustments. But it's pretty true. It's sort of like that same this kind of a colloquial definition of insanity now, which is doing the same thing over and over and expecting a different result. Well, if you do what you're doing more and harder, and you're still not getting the results that you want, then maybe there's a design problem or a logic problem with respect to the service and the things that you're trying to address. And that leads me to my next slide, which is my rant. And I see this is kind of grown a little bit well, at least off my page, but this is my rant on logic models, and it is, please use them. Develop a logic model for your program. They are so helpful for defining success, achieving clarity on outcomes you want to achieve, relating your activities to performance measures, and performance measures to outcomes. It's all there in the logic model when you're done. It helps you decide what matters. I'm sorry, what measures will be required. It informs the data collection strategies that you'll need to use to actually carry out your measurement processes. And a logic model provides you with a tangible record of your program model. It's there in black and white. It's compartmentalized in columns from your logic, your services, to your outcomes, to your performance indicators, to the actual measures that you're going to take. I know they're kind of a pain, especially if you've not developed one before. They do take some time to populate the various boxes in the logic model, but the returns will be bountiful. And again, my plea, really, for the love of God, spend some time developing a logic model. You can thank me later for this. I'll stop ranting now. But Cassandra is a queen among logic model purveyors. She's developed a logic model process, which may be available. If you all have not gone through that process of developing logic models, I strongly encourage you to do that. Okay, getting close to the end here. Next slide. Whoops. We've lost our Cassandra, are you there?
I think we may have lost her. I will attempt to bring the slides up on my screen.
Okay, thanks, Jill.
Can you all see them?
Yeah, I think those are, you need to back up a few. I think that's the end.
Oh yeah, sorry, I went that jumped ahead. Is this
No,
where you
no
were?
worries. Yeah, next slide after that one. Thank you. So, are we there yet? Yes, some axioms for performance measurement. This is kind of I hope, a colloquial and friendly version of some of the things that we've talked about. And I say this because these axioms are important because measuring performance indicators can be time consuming. It certainly does require resources. And pardon me. So these things will help focus those activities. First, we want to measure what's important. We don't want to spend a lot of time measuring things that aren't going to help us understand or lead to our outcomes. Measure what you can change. A lot of the studies that we looked at those years ago in the initial stages of this process, measures were like mined from other people's big databases, or they were measures of convenience. They didn't necessarily relate to something that you would expect to see change if your intervention was successful. So if you think you can change somebody's level of depression, then measure depression. It's important. It's likely that if you have a successful intervention, you could measure it with a standardized test or something. You have a reasonable degree of changing it. So focus on those things. Reducing the federal deficit by saving a few $1 million over 10 years in respite in Medicare recipients or Medicaid recipients, that's not on our plate. It's too far out. It's too disconnected. It may not change for a lot of things. Sorry, a lot of reasons. The next one is measure close. That is, look to the kind of the short future and measure those things that you want to track over time or that you have the best chance of influencing. And those are your proximal measures, and they will become distal measures over time. After you've got a bunch of families that you've dealt with, then you can start averaging the measures and making statements about the well-being of families and caregivers as a group over time. And pardon me, I'm locking up here. And then make sure that the indicators that you're measuring have been carefully selected to relate to your chosen outcomes. You've always got to maintain that link. Measuring things that either don't lead to an outcome or the connection is tenuous is not going to be particularly helpful to you. Next slide, please. Okay, and a couple of other measurement considerations. Some desirable features of performance measures. Standardization. Standardization is nice. The Hudson scales, things like the Beck Depression Scale, other scales that or instruments that already have credibility established. We borrow them from psychology, from sociology, even from medicine in some cases, and apply them to our practice environments. The next one, something that is dynamic. Dynamics are nice. That is things that change. And these are usually related to things like pre-post measures. You might have sliding scale scores. You might use things like Likert scales so that you could ask simply, very simply, in a matter of a few seconds, ask caregivers to rate their perceived level of stress on a scale from 1 to 10 or 1 to 7, with 1 being no stress at all and 7 being, ready to turn out all the lights and lock myself in a closet. And you can either develop homegrown scales like that, or you can work with measurement specialists to develop likely candidates. I only need 2 or 3 more minutes. I'm sorry about the throat issue here. The next thing is to keep it simple without making it dumb, or not useful. The old KISS principle, where you want people to understand these things on their face. You don't want to require that somebody have an advanced degree to understand the labels or the language that you're using. You're trying to gather data from caregivers, care receivers, particularly elderly, where their own cognition might be compromised. Even as a caregiver, they need to understand what you're asking. A couple of caveats. We haven't talked about these, but they're really important. One is to beware of the counterfactual. And that simply means if you didn't provide any service, is there a likelihood that the outcomes that you're interested in would occur anyway? So, I mean, that's, well-being being achieved in the absence of your service. And, people who want to cut budgets, who want to propose alternative policies or alternative methods, the counterfactual is kind of a home base for them. They say, well, why do we need you? If we didn't have you, nothing would change anyway. you're not really providing enough benefit. So be sure that the counterfactual can be explained, and that your measurement is specifically focused on those things that you do expect to see change, and that with enough data points you can notice that. Avoid performance measures that are rarely occurring events. There's lots of examples of this. And one of the things, like institutionalization, out-of-home placement. In addition to respite, there are a lot of services that are ongoing, medical services, even pressures from other sources to not place people out of home prematurely. So it's kind of it's a variable that you have to be careful about. If it happens rarely, if you have just again, the hypothetical example, you have something that occurs 3 times in 100 families, like an out-of-home placement over a year. 3 of those families would experience an out-of-home placement. That statistic of 3 itself is likely an average. Last year it might have been 5. Next year it might be 2, because it's a rarely, it depends on when you start and stop the measurement. That they don't occur at nicely sequenced intervals. So rarely occurring events can lead you down either the pathway of well-being, where you shouldn't be feeling that good about it, or they may lead you to turn your back on an otherwise interesting service purely because of chance. Rarely occurring events happened with odd spaces between them. And I could talk about that for an hour, because it's a very interesting measurement and statistical phenomenon. I won't, but just kind of salt away the idea that you want the things that you're looking at, that you're measuring, should have a reasonably good likelihood of occurring in the absence of your service. And then last, select measures or strategies that are designed to detect change. I've mentioned the Hudson scales, the Beck scale, even Likert scales that you design yourself. They're specifically designed for test retest applications, where if something does change, the instrument will show that, and you'll get different scores if you've detected that change. Not all instruments are designed to be used in test retest. There was a period of time when educational interventions in the public schools, the credibility was based on changes in IQ scores. Well, to many people, that might make sense. Yeah, the intelligence quotient should improve with a successful educational intervention. Probably not, because there's a lot of organicity associated with IQ. There's experience, there's racial overtones. The IQ tests have been developed with a dominant culture bias. And this is the one that people don't seem to understand. The older you are, the more difficult the IQ test becomes, because the reliability of the IQ test itself is intended to measure or to achieve the same IQ, assuming nothing else changes. So it's a very stable measurement system that is very difficult to change. And so you want to avoid things like that. Just you use simpler measures that are designed to detect change. And there are a lot of them out there. And I hope we get Cassandra back, because she's going to talk to you about some of those things in the next session. But I will, my last slide here, Jill, if you can pop that up, is to open it up for Q&A. We've used a lot of terms that are kind of floating around probably in your thoughts right now. You may have terms that I didn't use that you would like to explore or explain. Or if you just have an issue that you'd like to discuss, if you're thinking about an evaluation or a research study, if you're thinking about how can I measure this, how can I narrow the language around my outcomes? Let's go for it. And I guess I have to ask Jill, because I'm not a host and I have limitations here. If Cassandra made it back into the group or not.
I'm afraid Cassandra's power is out.
Oh, no.
The message I had from her was that she was going to try to connect by phone, but I guess she hasn't had much luck. But we certainly can open it up to questions now if people want to unmute themselves. Do you have any questions for Ray?
Hey, Ray, this is Susan. I'll start it out. I was listening carefully to your presentation. Thanks so much for it. And I'm going back to your independent variable, the respite services or intervention, and the positive outcome and dependent variable. And we haven't talked about measuring the independent variable, like documenting what you're doing. Would you talk about that a little bit, about the importance of that?
Yeah, thank you, Sue. That's really important. Mostly what I was asked to talk about today were outcomes and measures for outcomes, but it's really important to have a very, very clear description, pardon me, and definition of your service model. You can't just say we're delivering respite to caregivers of care receivers who suffer from dementia. That could be anything. That could be 1 unit of service. It could be 100 units of service. It could be hours. It could be in-home. It could be, using adult day services as part of it. So what you really need to do if you're trying to develop or generate a statistic of success, a measurement of success for a model, is to really accurately describe the model. Now, that model might not apply to all of the people that your organization serves, or that the organizations that you, if you're a grantee, the organizations in your state that you work with, consult with, perhaps fund, they may all have different, or they may have many different chosen service recipients or ways that they deliver. A volunteer respite service, a faith-based respite service that is made available at little or no cost, is likely going to provide different kinds of observable, different kinds of respite than one that has, like a credentialed in-home quasi-medical respite, because the service recipient has those kinds of needs and the respite requires that be done. So, what is the dose? What's the vehicle? If we're using volunteers and we're delivering 1 hour a week or up to 5 hours a month of respite, that's starting to home in on it. If we're a service that provides respite to medically fragile children or adults, we may be providing a professional funded or reimbursable through some insurance or Medicaid program respite, and it may be done in a medical setting, so that the respite is actually achieved by having the service recipient in a care home for a weekend or something like that. Whatever those variables are that describe your program, you need to identify those. And to the extent possible, there's always going to be some variation, but to the extent possible, you want to be able to talk about this group of caregivers who share A, B, and C. They have medically fragile children. We provide a service that is residence-based or clinic-based or in-home, whatever it might be. Identify it so that the measures that you take have the best likelihood of being influenced by your service and not by a bunch of other variables. Like, well, half the half the kids weren't all that medically fragile to begin with, and all they really needed was, close supervision, and it was, done in home, or, we had to do them all in the clinic, but, those are different features of the model. So defining the model, what is the independent variable? What is the respite model that we're testing? The more precise you can be with that, the more likely when you measure something, you'll be able to outcomes in ways that you can't capture. You can only speculate. So does that get at it, Susan, for you?
Yeah, it gets at it. And I think you're getting at what Leanne was talking about when she talked about account for variability. And it made me think about when I started my graduate school, there was a presentation by a researcher named Hill Walker who said, when things go wrong in the research, he loved that. It didn't make him upset because it was a time to discover. And I think the discovery comes from what you're talking about, those intervening variables. And, we account for those. And example from one of our best practice program, exemplary practice programs, they have, they serve aging people with memory problems like Alzheimer's. And one of the things that happens in their programs is it's a volunteer model, and it's documented, manualized. They keep their volunteers, some of them have been there for 20 years. And one of the ways, I'm just speculating now, but one of the things I think makes a difference is that they match. So when they were having issues about keeping volunteers, they just these different intervening variables, like how far people had to travel, their language, their culture. So they started this recruitment and matching program, and then changed their model so that information about the intervening variables, they incorporated as part of their model. And then they measured the outcomes, many in terms of quality of life, but also in terms of reduced isolation. So that what Marilyn Sword was saying about that developmental evaluation, if there's variability about the care recipient, I don't know, maybe you hire somebody for training that has that nursing experience, or who was a parent of somebody, and bring them in to the team and try and control for that variable in innovative ways, make that part of your model, and then measure the outcome. So don't be afraid of variability, I guess is what I'm saying. Just figure out a way to document it and play around with it.
Yeah, well, that's a good point. There's no way you can control everything. Even in a laboratory setting in animal studies, you can't control everything. You can control a lot. And that's where the kind of the anchor definition of control group is a group of comparison subjects where you can control virtually everything, so that there are no or very few intervening variables. Society doesn't work that way, and we don't want it to work that way. So we have to adjust our methods and our research approaches so that we don't decide arbitrarily to withhold service from somebody who could benefit from it. We have to figure out ways to monitor and measure those variables along the way. It's a really good point. But the more things you can identify that might affect your outcomes that aren't part of your model, like running a study in the winter in Vermont, where the days are 5 hours long, and your outcome variable relates to depression. We have a thing up here we call seasonal affective disorder. People get depressed from about the middle of February until Easter, because they haven't been outside in 4 months. They haven't seen the sunshine. They're locked up in their homes under the snow with, their families. And, you see spikes in child maltreatment and spouse abuse. And you see, spikes in depression. They're not attributable to anything you're trying to do with the kids or the family. It's because the sun isn't out, so you at least have to account for that and know that it might be a factor. So any other questions or?
Well, we only have a few minutes left, and I think Cassandra's not going to be able to join us. She was sending her sincere apologies for losing her internet and the bad weather they're experiencing in Seattle right now. I'm not sure what she was going to share about this document, but for those of you, and I think most of you are probably familiar with this, measuring systems change and consumer outcomes. And I posted, I just posted the link to it. I think Cassandra sent it to you, and I also posted the link to it on the website so you can find it at any time. I also have a number of hard copies that I'd love to get out of my my office. So if anyone would like a hard copy of this, let me know and I'd be happy to send you one. And Cassandra promises to talk more about this on the next call and refamiliarize yourself with what's available in this document. And I'm not sure what she was going to share about from the Friends Resource Center. So I'll leave it at that and apologize for her. We only have 3 minutes left anyway. So if no one has any last comments or questions,
Well,
do you
thanks,
would love a
everybody.
hard copy? I'll make sure you get one. And Marilyn would love one too. Okay. Make sure that if you both don't mind making sure I have your mailing address. I'm not sure I do. If you could email that to me, that would be great. I want to remind everyone that for those of you who are interested in our voucher learning collaborative, we have a voucher learning collaborative call next week, October the 6th. And we'll be following that the following week with the launch of our new faith-based and volunteer collaborative on October the 12th. And if you haven't gotten an email about either one of those, let me know and I can send that to you as well. Anyone else have any last comments, questions?
Just want to thank everybody for hanging in there. Apologize for my scratchy throat. I had a COVID test this morning and I'm negative, so I know it's not that.
Thank goodness.
Yeah. Well, I'm trying to get into.
I also want to thank you, Ray, publicly for, you always say you've only been working with me for 10 or 12 years, but I think we go back 20 or 30 if you count all the other years.
I'm old, I forget.
Ray really laid the foundation for all of the respite research work that we're proceeding on today. And I can't thank him enough for all the years of service, and we're going to miss him terribly. So this is probably his final formal presentation other than to our last meeting of our committee on respite research that'll be meeting in December. And then I'm sure he'll stop by and say hello once in a while, won't you, Ray?
Once in a while, I'll be happy to.
I know you're going to be busy with your wine and your Vermont living, but you're welcome to come visit us anytime.
Okay. Thank you, Jill. And thanks.
So goodbye, everyone, and have a wonderful rest of your afternoon. And thank you for being with us today.